Dear colleagues, good morning. I'm happy to introduce Hanna Rosa, a resident of our department. She will give a speech or talk about organ procurement. I think it's an important topic because, as you know, quality starts with the donor. Happy to listen to your talk. Thanks.
Thank you very much for the introduction. As already said, today I'm going to talk about organ procurement and thereby cover the topics priority of explantation, multi-organ retrieval in donations after brain determination of death, block liver and pancreas removal, kidney removal, complications of organ procurement, and the difference between a DBD donor versus a DCD donor. So, every explantation, every organ procurement starts with a laparotomy and thoracotomy through the visceral surgeon, followed by procurement of the heart, the lungs, the small intestines, liver, pancreas, and kidneys. And the reason why those organs are procured in this order is that every organ has a different time span till reperfusion has to happen. So the heart is procured first through the heart surgeons, then lungs, thoracic surgeon, and the rest by the visceral surgeon. And the reason why it's so important to have this certain time span and to be in this certain time span is because the cold ischemia time is so important. Can someone tell me what's the definition of the cold ischemia time is?
The time from cross-clamp till reperfusion.
Perfect. It's the time from cross-clamp until reperfusion. And thereby, the heart has a time span up to 4 hours, lungs 6 hours, liver and small intestine 8 hours, isolates of Langerhans 8 hours as well, pancreas 8 hours, and kidney up to 24 hours. But those are the maximum time to reperfusion, as it says right here. The faster, the better, because the organ function depends on the cold ischemia time. So the multi-organ retrieval in donors after brain determination of death. One has to know that every donor, every organ procurement, there has already been some organ injury going on. Those are not healthy patients or healthy people as you and me, but those are patients who have already underwent different treatments, different medications. So the procurement itself has to be done with the minimal injury as possible, with as minimal injury as possible. And thereby there's an in situ cold flush mandatory. And one has to know that there are different flush solutions for abdominal and thoracic organs. For abdominal organs, we use IGL solution. It's a colloid solution. Then, as already said, every procurement adds additional organ injury. Then there's a difficult preparation after cold flush due to you can't feel the pulsation of the arteries anymore and the vessels are empty. And you have to know that there are several transplant teams with different interests. And most of the time it's an unpleasant time. It's not a scheduled operation at 10 a.m. in the morning, but most of the time it happens in the middle of the night after a whole day of working already. There are different procurement techniques. On the one hand, the dissection in the cold, on the other hand, the warm dissection technique. Dissection in the cold is mandatory for unstable donors and it decreases the operating time. The warm dissection technique, on the other hand, increases the operating time. It leads to more vasospasms, to higher oxygen consumption, and there are more parenchymal and vascular injuries. So thereby, the graft function goes down compared to dissection in the cold. To the multivisceral procurement itself. It starts by the excess, the exposure of the abdominal aorta, iliacal arteries, Vena, Cava, mobilization of the left liver lobe, and control of supraciliac aorta, followed by cannulation, perfusion, organ procurement, and packing. Starting by the excess, as already said, with a laparotomy and thoracotomy, and the surgeon has to check whether there are any malignomas, because that's an absolute contraindication for organ donation. Next step is the mobilization of the right hemicolon and exposure of the retroperitoneum. And this maneuver has a certain name. Can one of the residents tell me the name of this maneuver?
That's a tricky one. I think it's the kettle barrage maneuver.
That's correct. Thank you very much. Followed by the Koch's maneuver to mobilize the duodenum. Then there's the preparation of the vessels, and one has to look for the landmark, the left renal vein, following by preparation down the vessels to the aortic bifurcation and to the proximal common iliac arteries. The proximal common iliac arteries are very important for cannulation. So after preparation, you have to put a tie around each one of them and a tie around the aorta as well. If you're planning on also cannulating the vena cava, you have to put a tie around the vena cava as well. Then there's the dissection of the left triangular ligament to expose the suprahepatic vena cava inferior. And you always have to be careful, because here in the lesser omentum there can be an accessory left hepatic artery, which also would have to be dissected in the worm. Then there's the control of supraciliac aorta by opening of the diaphragmatic hiatus, blunt retroaortic dissection, and again a tie. This could be the stop of the preparation. Up to now, the cold dissection can start. Some surgeons or some other centers also make a preparation, the hepatoduodenal ligament. There you have to check the pulsation again and visualize the distal bile duct, because there can be, as shown right here, an accessory right hepatic artery. Now, the abdominal part at first is done, and there come the heart surgeons and the thoracic surgeons, starting with the preparation of the heart and the dissection of the pleura. Then there's the heparinization and the cannulation. In the heart, the aorta ascendens is cannulated, in the lung, the arteria pulmonalis, and in the abdomen, arteria iliaca communis dextra, as shown right here. First, you start with ligation of the iliac arteries by knotting the ties that we've already put there before, and thereby the perfusion of the legs is closed. Then there's the incision of the aorta at the bifurcation and the insertion of cannula, and again, you remember the tie that we put around the aorta, that has to be closed right around the cannula. Now the perfusion starts. It's the cross-clamping of the supraciliac aorta. Can someone of the residents tell me which important time point starts now? We already talked about it.
That's the starting of the cold ischemia.
Correct. Right here, as soon as you cross-clamp the supraciliac aorta, the cold ischemia starts, followed by a cut of the supradiaphragmatic or infrarenal vena cava and the blood replacement by IGL solution and ice-cold water intra-abdominal. As soon as there's a proper cooling, you can remove the ice and remove the extra fluid to go on with the en bloc liver and pancreas removal, where the liver, pancreas, and kidney have to be exposed. Starting by the incision of the diaphragm, division of the right gastroepiploic and right gastric artery. And the best way to do that is by shaving the stomach to make sure to not injure any other vessels. Then there's the stapling of the proximal duodenum, the division of the left gastric artery and vein, and the stapling of the proximal ileum. As you can see right here, those can be your first stapler lines. On the back table, you can perform a resection. Then there's the transection of the superior mesenteric artery and vein, where one has to also resect a patch, and the transection of the mesenteric root via stapler. To mobilize the pancreas itself, start by transection of the splenocholic ligament, and then you grab the spleen and use it as a handle or as a hand grip to mobilize the pancreas. Now dissection of the vessels, starting by dissection of the aortic part of the superior mesenteric artery and celiac trunk, and transection of vena cava inferior above the renal veins. It's very important to, as already said, transect above the venal veins, because you need the vena cava inferior and the venal veins for the patches of the kidney removal. After transection of the adrenal glands, the organ is out, the kidney, the liver and pancreas are removed, and you can place the organ in IGL solution. And it's important to rinse the common bile duct and the vena porta properly. Next step is the removal of the kidney. First, you start by opening the abdominal aorta, where you can see the osseous very beautifully. Cut off the abdominal aorta and inferior vena cava above the bifurcation. Mobilize each kidney to the bone, including the pararenal and perirenal fat and the ureter. Then, as already said, mobilize the aorta patches and the vena cava inferior. That's the reason why it's so important to keep them. Cut the ureters close to the urinary bladder and place the kidney again in IGL solution. A procured kidney shouldn't look like this example, where you aren't even quite sure which organ you have right in front of you. So the perirenal and perirenal fat should be removed on back table preparation. Considering the organ conditioning, in the first bag you put the organ in ice-cold perfusion solution, then second bag sterile ice-cold perfusion solution, and the third bag is empty. Then whole organ, whole bags in a crushed ice box or in a cool box with crushed ice. Every organ should be accompanied by blood samples and by a sample of the spleen, because the spleen will be examined by immunology. Then the NRECA report that tells the surgeon who is afterwards transplanting the organ what has been going on during the operation, how many heparin has been administered, and in liver and pancreas, the iliac vessels. Complications that can happen during an organ procurement are liver tears, especially in the dorsal right side, or liver vascular injuries, as you can see right here, where the vena cava is inserted, or right here where arteries are on one hand ligated or totally transected, or part of it is transected, and the vessels that are transected can be too short for suturing anastomosis in the recipient. The post-procurement care of the donor is first closure of the sternotomy and laparotomy, then there can be a donation of the cornea and the transportation to pathology. Overall, in a patient, in a DBD patient, the steps that I explained right now should take about 1 hour, and cannulation a half an hour. If we're talking about a DCD donor, the whole preparation, where, as already said before, can take 1 hour in a DBD patient, should take only about 3 minutes in a DCD patient. And now I would like to explain you what's the difference between DBD and DCD, and what's the reason why organ procurement or preparation has to go that fast in a DCD donor. So, at the beginning, DBD, donation of the brain determination of death, and DCD, donation of the circulatory determination of death. Here we see a chart from the Swiss transplant that says in 2017 there have been 106 DBD donors and 39 DCD donors. There's also the chance of receiving a living donor organ, and in 2017 we had about 137 living donations. So you can see in both graphics that the numbers are rising. And it's important to have a living will or an organ donor card or online registry to inform your medical treatment team and your relatives what your thoughts on organ donations are. One has to know that in DBD donors there is no brain perfusion. So as soon as you would stop the respiratory, there would be no spontaneous breathing, there would be no reaction to pain, there would be no corneal reflexes. The patient is in a coma, and he's not reacting anymore, so he's brain dead, no brain stem reflexes anymore. But there is still a circulation, so it's a local stop of perfusion. In a DCD donor, you don't have a brain perfusion and you don't have a circulation, so you have a generalized stop of perfusion. So at the time point of death, it's important to know in DBD donors, there's still an organ perfusion, although brain death. In DCD donors, there's no organ perfusion. And that's the reason why you have more time to prepare or to operate a DBD donor, because there's still a spontaneous organ perfusion, which you don't have in a DCD donor. In DCD donors, we have to perform a therapy discontinuation. The only reason that keeps the blood moving, that keeps the toxins of clearing in a DCD donor is catecholamines, is continuous renal replacement therapy, and medication administered at the ICU. So, a DCD donor is a donor with an infused prognosis, no brain perfusion. Then you start checking the organs. Are they good? Can they be allocated? Is there a chance of transplant? And if it is, then you perform a withdrawal. The patient goes into asystole, which is checked by a transthoracic echocardiography. You check the brainstem reflexes, and then incision, perfusion, and organ removal. To show it on this slide, therapy withdrawal, then you wait till the mean arterial pressure goes down under 50. This has to last at least for 2 minutes or up to 60 minutes. If it lasts longer than 60 minutes, you can't procure liver, kidney, and pancreas anymore, because there has been a too long time span of hypotension and the organs have suffered too much injury. Then there's the asystole. As I already said, you have to confirm it by echocardiography. Then 5-minute no touch and time of death. Then right here at this part, there are just an intensive care team, and now the surgeons come in and start the operation till the cold flush where the cold ischemia begins. In comparison, in a DBD donor, you also have an in-house prognosis. You have a brain death, and then you have some time to check whether the organs are still good enough for allocation and transplantation. Then there's the incision, preparation, asystole, as already said, cross-clamp and organ removal. And this part happens in the OR room. So the withdrawal happens in the OR room on the DCD donor. In a DBD donor, you go right in for the organ removal, which would now bring me again to the start of my presentation, thereby to the take-home messages. The organ function depends on the cold ischemia time. One has to perform organ procurement with minimal injury because there has already been some injury. In DBD donor, there's no brain perfusion, but still spontaneous organ perfusion. DCD donors, no brain perfusion, no organ perfusion. And it's important to have a living will to inform your relatives, your medical treatment team about your thoughts on organ donation. Thank you very much for your attention.
Yeah, I think I have to stand here because to summarize some important points. Many thanks. That was a very good presentation, but the talk is very demanding. We touch here ethical things, technical things, organ procurement, organ quality. So I think what you want to know is at the time of procurement, it is always in the night. So this is not a nice time. You have always a rush between several teams. You have always in a foreign town or even in a foreign country, and you have always to perform a difficult surgery underwater. So this is basically underwater surgery because many of the steps, as you saw, are in the cold nowadays. And it's important to know that in spite of more than 40 years transplant activity, standard operative procedure for this kind of operation, which is not an easy one and very demanding, and I think involving many recipients. If you, for example, take 5 organs, you involve 5 recipients, so responsibility is high. So there's no standard operative procedure in Switzerland, and in Germany it was a little bit faster, but since 2 years we have only a standard operative procedure for this procurement technique in Switzerland, despite 40 years activity. So there's less standardization compared with the transplant procedure itself. And therefore, it is very important that you summarize what we are doing. And most of the steps are in fact done in the cold nowadays. So it's important that you realize that the time between begin of the skin incision until cold flush is only very short. So it's actually probably a mistake if you spend 3 hours preparing the aorta and preparing the vessels. It should be not longer than 1 hour until cold flush. That's the first point. That means that you have most of the steps in the cold, and that implies several mistakes. It is clear that you cannot say everything because I think you only witnessed one procurement, right? So that has to be said. Therefore, it's very good. But importantly, most often we have mistakes at the arterial vessels. Arterial mistakes is the most demanding thing, and the organ which suffers most is the kidney, because the heart is taking first, then the lung comes out, and afterwards the liver, and then the pancreas, and the organ which is really in the last sequence is the kidney. So kidney injury is the most frequent injury during procurement, and that has to be known by the procurement surgeon. So in fact, kidney vessels or vascular injury of kidneys, not very often, but vascular injury. And most of these injuries can be repaired by experienced transplant surgeons, but it's important that you understand that. And what we did not discuss here is the value of machine perfusion. That changes completely the field. So you can even harvest today or procure today organs without any ischemia if you plug machines, for example, in situ. You plug the donor to machines and you take out the organs without any ischemia. I don't know if this will ever come, but in principle we are witnessing a change in the whole procedure. If machines are coming, that means machines for lungs, for hearts, for livers, for kidneys. So everything will change, I guess, in the next 10 years. And which we did also not cover is the principle of organ preservation. So the many solutions which we have it's important that you understand there are different, unfortunately, different solutions for livers, for lungs, and for hearts. So you have 3 different compartments, if you may say so. So there are 4 solutions for abdominal organs, which is IGL, which we use here, UW solution, which is mainly used in US, and Celsior, and HTK, histidine, tryptophan, ketoglutarate, Brett Schneider solution, which is used in Eurotransplant. So 4 different solutions for abdominal organs, and to make it more complicated, for lungs also different solution, and for hearts. So that is important to understand that there's many physiological things behind that, but we could not cover that. So I'm happy to answer questions. Thank you very much.
Small question. When we did organ procurement in Germany, we didn't have any DCD donors. What is the ethical dilemma, or is there any dilemma and discussion? Please help us here.
So that is, of course, also something which we could not properly. So I think the ethical issues are extreme high here. The important thing which you first have to say, there's no difference between brain death, between DCD and DBD, so both are brain death. There's not a death which is called cardiac death. There are only one death. Death is here in Switzerland, brain death. So both are brain death. But the difference is you have much more time to determine a brain death in DBD donors. That is usually 24 hours and done by different teams, while in DCD donors you have only 10 minutes or 5 minutes since 1 year in Switzerland. So that is the important point. So in fact, the donor, MASTRE 3 donor, is someone where we withdraw the treatment and the brain is still functioning. Important to know that the donor is coming in the OR or on the ICU, treatment is stopped, and afterwards we wait for cardiac arrest, which is here defined by echocardiography. Some centers define it by ECG, so the Nulllinie, but here by echocardiography, and afterwards, after the standoff period, the neurologist is checking the reflexes, and that is done in a short time. So you can argue the time is too short for determination of brain death, and that is the ethical dilemma. In Germany, this time is at the moment 24 hours. So therefore, in Germany, DCD is not existing instead of the other countries, so like UK, Netherlands, and Spain, and Switzerland, and also Czechia. So that makes a difference. But the important point is not the time of determining death, it is the irreversibility. So the people here which check that are sure that the reaction of the brain is irreversible if we determine that after 10 minutes and check properly. Yeah, it's important to know that the surgeons are not involved until this point. So surgeons must be invisible until this point. We wait usually outside. If the donor is not proceeding, if there's no cardiac arrest, then we don't show up. Yeah, please.
Thank you very much. Very nice presentation. Difficult topic here. Maybe one comment or a question here. In a department of surgery or general surgery where transplant is part of the business, there is a question who should do this harvesting, and as we have shown, it's pretty complex, and mistake will lead to primary non-function and sometimes death of the patients. So maybe my question here is who in a department like us should be involved in this harvesting. This is a big business, depends how many transplants you are doing, but when you start to have significant number of transplantation and a relatively small team of transplant people, then it's a duty for other people also to be part of that. So maybe the question here is who should do this procedure and what is the training? The comment here also is that this is an operation here where you learn a lot about the anatomy. And in surgery, anatomy remain today still very important. Not knowing the anatomy lead to disaster in any kind of surgery. So this is an operation, I remember my old time, this is really where I started to understand completely the anatomy, because of course you not operate the same way you operate in a patient, but you learn everything that you don't see otherwise. So maybe I come to the question in the department like us, which are many, in fact is the most common. There is department dedicated only to transplant, so that's easy, but in many places in the US or here in Europe where transplant is an important part, but not the only surgery that we are doing. So who should be involved in these procedures and how do we secure quality?
You want to comment that? No?
You can go first.
Yeah, so from my point of view, which is of course subjective, the young Oberärzte are doing this procedure after proper training by us. By us means the transplant surgeons. So in principle 10 to 20 procedures as an assistant or actively training that qualifies from our point of view to the procurement. And I think it's from my point of view, it's very important that the chief residents and the fellows can do that independently. It is also important that they are a little bit involved in the transplant procedure. From my point of view, it's much better if they understand what happens after the procurement. So they will have more understanding if they see the organ on the back table and even witness a transplant procedure because they understand how we repair, for example, injury. For me, the whole picture is much better if the young surgeons are doing that and they are then very motivated, and I think that would be very important. We do training, therefore we do in Switzerland training and also in Europe. We send the youngs to the courses which are offered by ESOT and also Switzerland meanwhile and also Germany, and I think it's an important part of the transplant business.
Thank you for the very nice talk. I have one question. Why do we have more lesions or more injuries when we do warm preparation?
So I think it's not quite correct. You have, I think if you prepare everything in the warm, you of course have more identification of the vessels, and in fact you will have less injury at the arterial vessels. But you can cause reperfusion injury or in fact ischemia. So for example, if you completely prepare the hepatoduodenal ligament, including the GDA, the splenic artery, the common hepatic artery, it may happen that you have some injury to these vessels, and that can potentially cause, of course, liver ischemia, and then you have, of course, a sequence of that. So therefore, the summary at the moment in Europe, at least, is not to touch the main hepatic vessels. Do that in the cold. But that depends, of course, of your experience. If you are a master of preparation of the hepatoduodenal ligament, it will not happen, but you spend considerable time, and that will block also the other teams. So at the moment, I think the procurement is done that you have relatively short time of preparing the important steps until cannulation and do most of the procedure in the cold. And as we are now witnessing a DCD period where you saw that everything is shut down to, let's say, 5 minutes. So most of the surgeons which ever did super rapid retrieval, they of course don't spend many time if they switch suddenly to DBD because they learned how to do it in a very quick manner. So that is also something.
Beautiful presentation. Thank you very much. My question is, you're always working under time pressure. What do you do when you have an unexpected finding clinically, especially during DCD organ procurement? You find some thickening of the colon or you find some focal lesion on the liver that you're not sure about. Do you wait for frozen section? Do you harvest and take frozen sections? How do you address that?
The first step is don't panic. Behave properly, because we have several not nice behavior during this procedure which has to be avoided, strictly avoided. Always be calm and always call the background surgeon. So if you have something unexpected, just give a call to the transplant surgeon in charge. So in the liver, you call. Of course, if you know that, then you make a frozen section. If it is unclear, just call the transplant surgeon. Don't panic. And don't just say, I will not take care of this node, I don't care. So it's good to call someone who takes the responsibility for unexpected findings. Okay, thank you very much. Thank you very much. Thank you.